Hello, I'm Viraj Master. I am Professor and Frey Marshall Chair of Urological Research in the Department of Urology at Emory University. I'm Director of Clinical Trials in the Department of Urology and Associate Chairman for Clinical Affairs and Quality. And I'm also the founding inaugural director of the Center for Integrative Oncology and Survivorship at Winship Comprehensive Cancer Institute at Emory University. Many of my medical oncology colleagues ask me, what are the appropriate organ-sparing approaches to a patient with penile cancer, and really which patients can they be used on? The real detail is how extensive is the penile cancer. If it is a superficial penile cancer at the surface of the penis, the patient and their treating oncologist have multiple options. They range from the use of topical chemotherapy, fluorouracil, which is applied to the phallus a few times a week, to topical immunotherapy called imiquimod, which is applied to the phallus, again, a few times per week. And this is by the patient in the comfort of their own home. Stepping up from that, patients who perhaps might be recalcitrant to self-apply therapy to their phallus can undergo laser treatment of the cancer. So this can be done with a variety of lasers depending on how deep the penile cancer is. Further from that, if it's believed that local therapy is not going to treat the tumor effectively in terms of laser or topical chemotherapy, then there can be a wide local excision. So this is where the tumor and a small margin of normal tissue is removed and the phallus is sewn back together again. This results in very small amounts of cosmetic deformity. Occasionally more advanced surgical techniques that involve plastic surgical techniques where lesions or tumors that are on the surface of the top of the penis, the glans penis, might require what we call a glanzectomy and then plastic coverage of that area. These all result in the patient preserving the normal length of their penis without much cosmetic deformity. However, after that, if these lesions are not treatable with the previously mentioned procedures, then the patient has to undergo an amputative partial penectomy or a total or radical penectomy where the entire penis is removed. A partial penectomy is done to remove the tumor with a small margin. Usually that margin can be as little as 1 to 5 millimeters and is designed to leave the patient with a stump of their penis that they can void or urinate in the standing fashion, and ideally is long enough for penetrative intercourse. Finally, and lastly, if the tumor is so advanced that it destroys most of the penis itself, then a radical penectomy is performed to remove the entire penis all the way to the crura of the penis, curving underneath the tibia, proximal tuberosities. And then the patient is given a perineal urethrostomy, meaning an opening in their perineum between their scrotum and their anus to allow them to urinate with full control, but in a sitting down rather than standing up fashion. So in essence, it all depends on how extensive the lesion is. Surface lesions have a tremendous amount of variety of treatments afforded to them, and more invasive lesions have rather few opportunities for cure, which are amputative partial penectomy or amputative radical penectomy.